Good morning, everyone, and thanks to Dr. Peterson and Dr. Urbach, who is probably hiding somewhere, for the opportunity to present our work today. And thanks, Raj, for a great kickoff, very inspiring to start with. Before I dive into this, tell me who you all are. How many of you are residents? How many of you are fellows? How many of you are faculty? So thanks. Yeah, exactly. Well, kind of about what we expected. That's good, because that's kind of how I designed my talk. So I am going to, well, let me get my disclosures here first. I have grant funding from the National Institutes of Health and AHRQ, and I'm co-founder of a company that makes software for profiling hospital quality, which won't have anything to do with this talk. So I think when you think about building your research program, and for those of you who don't have a job yet, at least it sounds like 2/3 of you don't, the key is to start with finding the right job. And I think it's really importantly to think about the right job for you. And you'll find that theme in here a lot, because there's a lot of different phenotypes that you can pursue as an academic surgeon or as a clinician scientist. And I think the key is to find, have the right mix of scholarly and academic work, or for clinical and academic work for you. And then probably more importantly are the expectations aligned with your goals? When people fail at this, it generally isn't from a lack of enthusiasm or lack of passion. It's usually they don't have the right resources or environment. So what does it look like? Well, there's a bell curve of jobs out there. There's jobs you can take where you're going to be doing a lot of operating, and on the other end, there's going to be jobs where you're doing lots of research. And let me start with a little quiz here. Which is the right point on there? Which is the best job? Right. There's no right answer. Right? Some people will tell you, oh, you have to be over here. Otherwise, if you don't operate 5 days a week, you're a lousy surgeon. Or some people tell you, if you're not doing research 3 days a week, you're not going to be a successful researcher. That's all crap. Don't listen to anybody. Everybody likes to justify their own situation. You need to find where you want to exist on this spectrum. Okay? And you can be successful anywhere on the spectrum. You just need to figure out exactly where it is that you want to be. And I already mentioned this, but number 2 is, does that opportunity, once you figure out what you want your balance to be, does the mentorship in that program and the environment match your goals? So putting up the same figure, if your goal is to be a clinical expert and move the needle on doing paraesophageal hernia repairs and do randomized trials of that, you need to go to a place that has the clinical volume or the capability, and probably a mentor who's really good at that, a clinical expert. On the flip side, if you're looking at a job that has a ton of research, you want to make sure that you're actually going to have a legitimate amount of protected time, and that that's a common phenotype in that institution, and that there are people there that can help you get there. I just was talking to a junior faculty who was hired into a role where he's going to start an outcomes research program in a place that's never done it before, and he's not funded, and he's asking me advice. And I'm like, well, my advice is you took the wrong job. Right? That's my advice for you. I'm sorry to tell you that. So you really need to think this through. Right? And that doesn't mean you can't rethink where you want to be on the spectrum, depending on the opportunity and environment where you're in. But if you're 2/3 of you at least have this opportunity to think about what you want your life to look like. So I think that one theme here, and we'll round out this first section here, is you need to be self-aware. You really need to understand what you want to do with your life. You need to know thyself. So does anyone know who this gentleman on the left here is, with the number 5 in his shirt? Anyone? That's Jabril Peppers. Jabril Peppers was a Michigan defensive back a few years ago. He was a Heisman Trophy finalist, and he was when you make the Heisman Trophy finalist list, you're pretty good at your craft. And does anyone know who that is on the other side? Yeah, that's my son. That's Paul. And so Paul and I sometimes work out together in the basement. We have a basement gym, and he comes down with me. And I said to him one time, not too far away from this picture we're taking, I was like, Paul, let's go to the basement in a couple more weeks, and I'm going to look like Jabril Peppers. And one day he just stops and looks up at me and says, no, Dad, you're getting old, your muscles are shrinking, and they're covered in fat. Yeah, and I was like, you're right. But my goal isn't to be Jabril Peppers, right? He's 20 years old, older than that now, but he has a certain goal, and in his stage in life, and mine's different. So, yeah, exactly. Someday he'll be 45. So I think the key is to know yourself, and have an accurate vision of that, right? And you can get help with that. You can get feedback. You heard a lot about Raj talk about his journey of self-discovery and getting input on that. I think that's kind of the key here. And Also, so remember two things. Figure out how to know yourself, get advice. Second thing, know where you want to be in that spectrum and own it, right? Just be comfortable with it. And don't listen to people when they tell you that you need to be somewhere else on the spectrum, because it's a totally individual thing. Now, fundamentally, the goal here is you have to figure out how to balance your academic and clinical work, as I talked about. Let's be honest, we all like to be in the operating room. I'm just looking, I don't know how many of you, but I look at this picture, it makes me want to go operate, right? This is a jejunostomy. I want to like finish it up, right? I have this intense drive to do that. And I think we get scared a lot of times when we're saying, well, we're competing with full-time scientists, right? Like, how can I, as a clinician, an MD, who maybe got a few years of training, maybe not, how can I compete with people who are full-time scientists? Right? It's almost like David and Goliath, right? And this gets into this, people can get to morals and say, well, why even do research? Well, I think there's a lot of reasons to do research. First is for self-actualization. You're contributing to something greater than yourself. You're moving the needle forward in our field. You also get to mentor and develop the next generation. If you're going to be in an academic situation, people are going to come to you, and you're going to be productive so that you can help other people be productive ultimately. And then if it's part of your job, depending where you're on the spectrum, getting promoted may be an important role as well. So that's what I tell my research fellow is, remember, David beat Goliath, right? You can do this. You can beat people who do full-time research. And why is that? Well, we have certain advantages. And I see this all the time. I chair a study section for the NIH right now, and I sit there, and every time the clinicians always write better grants. No offense to any PhDs in the room, but the clinicians who collaborate and understand the methods, because they ask more interesting questions. They know the clinical operations, the clinical applications. They have access to patients and materials. And you know where the problems are in your health system. This is a theme that will come up again and again, because I'm going to call on you all to think a little differently in a few slides about how you ask your research questions and where you find, when you build your program, what questions you pursue. So I think the key principles to finding these basic research questions, and this are finding the best research questions, and this is what I think of when I think about building a program, it's about finding these great questions. You can study your clinical practice, and that allows you to capitalize on these competitive advantages. You know what the important questions are. You have access to the patients. But we see a lot of that, right? And just writing up your next case series of my 30 lapnisins or my 20 redo lapnisins, right? Like, that's interesting and useful, but not particularly novel, not particularly creative. So I'm going to call on you a little bit to think differently when you build your research program. And we'll give you some examples. So I call this taking your research up a notch. Right? And I think there's three ways to do this. One is to think bigger, and I'll give you some examples of that. Don't just write up your experience. Work with people from other institutions, and that offers some unique advantages that I'll spell out. The second one is think smaller. People publish kind of very typical clinical research, but it's not too hard to take a step deeper and try and understand data from a different perspective or in a different way that we normally do, and I'll give you some examples of that. And then finally, think different. When you look around, there are things happening all over your health system, right? I'll give you an example. You're in the OR, and there's a senior surgeon who's a jerk and is yelling at the staff in the OR, and they're doing a lapnisin, right? Like, what's more interesting in there? Writing up the lapnisin experience or understanding why surgeons bully people in the operating room, right? Like, I think the bullying is a much more interesting thing to study because it's probably a much bigger problem. The nisin probably went just fine. So I think when you think about thinking bigger, this is Tim Pollack, who's the chair of surgery at Ohio State. He's made a career out of doing this. He basically takes diseases like something like gastric cancer, right? And he gets 7 or 8 of his friends at other institutions, and they form something called a U.S. Gastric Cancer Collaborative. What is that? That's like 8 friends collecting data together. Same data elements, same database, and now what you can do, you can study 960 patients who have a relatively rare disease. And that, all of a sudden, that's way more interesting. And if you go and you PubMed Tim Pollack, you'll find that he has about 700 papers. About 500 of them, sometimes he's senior author, sometimes he's middle author, sometimes he's first author. His fellows are first author, and they rotate authorship, and they come up with different questions because they have this powerful data source. So don't just write up your experience. Find your friends and write it up together. It's a more powerful tool. This is another example of, once you have more than one center, you can do things like study differences, right? You can study practice variations. So this is another colleague, David Miller, who's a urologist, and he basically created, when he finished, he went to 3 group practices where he had a friend. And on every patient with early localized prostate cancer, like one disease, they collected 1 page of data. 1 page of data on these people, and they studied how it was managed differently across 60 urologists. And this ended up with a bunch of papers, this one here, and it ended up creating this popularized this concept of having this urological surgery collaborative, and eventually the American Society, or the American Urological Association, eventually launched and went with this and rolled it out nationwide. But it started as just like David and two friends, like trained in fellowship at the same time, coming together to study practice variations. So thinking differently about it, creating powerful instruments for change. This is the example I gave before. So this is Amalia Cochran. Some of you may know Amalia. I love her research because she studies disruptive surgeons. And this is getting into the thinking smaller. Okay, the first two were thinking bigger. This is thinking smaller. So how do you think small? So she studies this by doing semi-structured interviews with 19 operating room staff. Right? Totally different way of thinking about the world. This is something called qualitative research. It's a really valuable tool if you want to understand really interesting things like why surgeons throw instruments in the operating room and what we do about them and whether or not those policies are successful. Fascinating topic, right? And this was published in the Journal of the American College of Surgeons. And she's done some on mentorship, specifically among women surgeons, mentorship and sponsorship, like really interesting topics that you can dig into by thinking smaller. Another way to think smaller is to get even more detailed. Start taking videos of the procedure and use the videos as data. And this is Oliver Varban, who's a junior partner of mine, and this is a project he's working on where he's essentially using videos from all over the state of Michigan to understand kind of the micro technique variations and link them to outcomes so that he can disseminate them back throughout the state. And this is an example. So this is very detailed, right? We're thinking really small here. We got videos. This is a sleeve gastrectomy divided into three pre-staple, staple, and post-staple. We have kind of a checklist of how well everything was done. We also have a skill assessment using OSATs, and it's going to be really interesting data. And I would argue more innovative than just saying our leak rate after sleeve rate is X, our GERD rate is Y. Right? We're going to understand the details. So the last one is kind of thinking different. And if you look at this meeting now, and really any academic meeting, they're changing a lot, right? It used to be everything was basic science, then it was outcomes and clinical research, and then education. And all of a sudden, social media, leadership, health policy, global surgery, anything you want to study, if you do it in a scholarly way, can be an academic focus, right? You don't need a lot of funding to do it. You can do like the qualitative studies Amalia did. She did those with local resources. And you can also dovetail them into a leadership role. She was a vice chair of professionalism in an institution, so she had access to resources to help her do the work, which was scholarly, but also served an executive function for the institution. So you can do pretty much anything these days. This is a plug. I'm a past president of the Association for Academic Surgery, so this is a little bit of a disclosure. But we now publish books on all these topics, right? Basic science, health services, education, clinical trials, global surgery, leadership. So good resources if you're trying to start pushing into an area. This is an example of like the crazy kids that come in and want to study interesting things. It's Andrew Ibrahim, some of you may know. He showed up on my doorstep, was really excited about design and architecture and how the built environment influences outcomes. And I was like, whoa. He spent a year in some architecture school in London, kind of had all this eclectic experience. So we brainstormed for a while, and we wanted to figure out a way to use that unique interest. And some of you may know, hospitals now are consolidating like crazy. They're creating these big networks of care. And so we were like, well, one thing that everyone's trying to figure out is how do we redesign delivery across a set of hospitals or assets. And so that's kind of the field that Andrew went into. And he eventually created some models and some case studies on what it looks like when you redesign care delivery across a multi-hospital network and you do it well. And this is a piece he had in the New England Journal Catalyst a while ago. So I think, once again, just to find something interesting to study. Dana Tellem, many of you may know, Dana's on the board here at SAGES. She is really passionate about gender equity. And I was like, why don't we do a national cohort study of that? So she wrote this wonderful grant here, which you can see called RAISE, Realizing Advancement in Surgical Equity Study, and here's her conceptual model. And it involves some qualitative work, so we're kind of thinking small, but we're also thinking big. We're going to do a national cohort study that oversamples women and minorities and compares them to men in terms of their barriers to advancement. Now, we haven't got this funded yet. We're shopping around at the NIH and trying to get it funded. But once again, thinking about things a little differently. It's not a randomized trial of mesh versus no mesh for paraesophageal hernia, but really important to our field. So in summary, I think you need to choose the job with the right mix of clinical care and research for you, and make sure that you have the right mentorship and environment that will help you achieve your goals, wherever it is on those bell curves that I showed. Because everybody has a different place, and Don't listen to people when they tell you there's only one place to exist on that curve. And then I think choosing the right research questions is really important. And I know a lot of you are on the younger side, so I'm hoping to inspire some of you to tackle some of these really interesting questions that we have to ask, the things that cause pain in your daily life that no one's studying. Right? Think about them and figure out a way. If you need to learn about qualitative research, take a course, read some books. You heard Raj, you can pretty much find anything you need to know is out there in the university, in the world. And I think there's a lot of great role models in this organization who are really pushing the boundary in a lot of these other areas, including qualitative work. It's commonplace in education research to use it. The video work and the coaching, there's a lot of individuals, including some speakers in this session. Both Raj and Dimitri are pushing that envelope forward. So opportunities to network, as Raj said, call people up, ask them to have a cup of coffee, and research creatively. Thank you.